Okay, now we are live, Dr. Guyuron. If you wanna wait some minutes so more colleagues can come in.
Sure.
Okay. So in the United States, there are a lot of universities and colleagues doing the surgery, right?
Yeah, actually, many are doing it. In fact, I don't know if you know, the third book was just published, and it was combination of different surgeons from different organizations that are doing the surgery, and I just wrote one preface and one chapter at the end, updating the last 20 years. So that's all I did. But the rest was written by the individuals who are doing this surgery and believe in this surgery.
Okay. So, Dr. Guyuron, I would like to thank you very much for your time and for sharing your knowledge with us. Unfortunately, we are not able to do what we love to operate yet. So this is a good time to learn from the masters like you. Dr. Guyuron is the great name in migraine surgery, is who developed all the techniques that we use today. So we are gonna have his talk, and we are gonna have some time to answer the questions from the audience. Okay, Dr. Guyuron, if you wanna start it.
Paula, thank you for the invitation. And I'm going to share with you some information about the migraine head surgery. And I hope that this would be something that would make your time that you're not using for anything else worthwhile for you. And let me just go to share. And here we go. Are we okay, Paolo? Can you see the presentation?
Yeah, now I can see it.
Wonderful. Okay. These are my disclosures, and obviously, I wrote this migraine surgery book, and everything that I'm going to say is going to be in that book. So, what I'd like to do is share with you some science behind what we have done to prove that the surgery works, how we detect the trigger sites from which the migraine headaches originate, the surgical techniques that I have developed, and the evolution from some of the major surgeries to some of the more simpler surgeries under local anesthesia, in a way that the patients can go home and resume their functions the same day. This whole surgery started by two patients telling me that not only they looked better after a forehead rejuvenation, the headaches were gone. Initially, when I heard that from the first patient, I thought that it was a coincidence. But after hearing the second patient, I actually started thinking that this is no longer a coincidence. And the fact that actually this story comes from the patients in a way negates the claim from the neurologist that this is a placebo effect, because neither the patients nor us at the time would have thought that there's any connection between surgery in the forehead and migraine headaches. However, this was just an anecdotal statement and didn't mean much. So I began a study. So we went back and reviewed 314 patients who had undergone a previous forehead rejuvenation. And of those, 39 had migraine headaches, 31 had experienced either complete elimination of migraine headaches or significant improvement. And you can see that the p-value is extremely strong. And the average follow-up period was 47 months. And again, this also confirms that our findings could not have been placebo, would not be placebo effect, because the patients didn't know why even we were doing this study. We just asked them questions, and they connected the elimination of headaches to the surgery. And this was published in year 2000, which, as you can imagine, is now 20 years that we have been doing these studies and surgeries. This was a retrospective study, and we know that retrospective studies are not that reliable. However, it prompted me to look into what is the connection between surgery and elimination of migraine headaches. I find an article from a neurologist going back to 65 years ago, indicating that in his opinion, the migraine headaches are about elimination of the terminal branches of the trigeminal nerve. What was not stated in that article is what is causing the irritation and what is the solution. And about this time, we started seeing articles about Botox, and I was involved actually in the beginning of this process also. And the only thing that Botox and surgery have in common, obviously, is the elimination of muscles in its muscle function. One is removing the muscle function temporarily. The other one is removing the function permanently by eliminating the completely. So this in mind, I began a prospective pilot study, a small number of patients, and I teamed up with a neurologist, and the neurologist confirmed the diagnosis of migraine headaches, and we had them complete some questionnaires and diary injected with Botox. If they responded to the Botox, we operated on them. And of the 22 patients that we enrolled on the study and underwent surgery, 21 complete elimination or significant improvement in the migraine headaches, and one didn't respond. The average follow-up for those patients was a year. And this was published in 2002. The question that occurred to me is, okay, if surgery works, why didn't all of the patients have complete elimination of migraine headaches? And we went back and questioned the patients. We discovered that where we operated on the sites that we operated on, the headaches were gone. The existing headaches were in different areas, areas of the head. And at the time, even the neurologist did not know that actually migraine headaches can be beginning from the forehead, from the temple, from the occipital area. So many of these headaches, residual headaches, were in the occipital area on these patients. So we went back to the anatomy lab and dissected 40 specimens and found that the greater occipital nerve in all 40 of those cases passed through the semispinalis capitis muscle to get to the skin level. And you can see the nerve here, and the needle is showing the nerve, and this is the midline. This is the semispinalis capitis muscle, which is the thick, long muscle, and this is the base of the cranium you see there, attaches to the cranial base. So designed a study to decompress this nerve. About this time, another patient who had undergone septoplasty and rhinoplasty told me that his headaches are gone. Obviously, when you hear that, you just said that it's something he hadn't heard for decades. You question yourself, am I just imagining things. However, I went back and searched the literature, and there was an article from Italy reporting 800 patients who had undergone surgery for headaches, and some of those patients actually had migraine headaches that went away, but it wasn't exclusively migraine surgery. So armed with all these pieces of information, we began a study, again involving a neurologist, a biologist, who is also a biostatistician, and also my nurse at the time. And this was a comprehensive study that has been published already, so I'm not going to go into the details. It was a randomized study, included a group of patients that did not have surgery. And we found that 89 of the patients who underwent surgery had numbness in the area of actually what we did. We looked into the adverse effects first. Anytime I do a study about new technique, I want to know what the complications are. So we looked to the adverse effects. Everyone has some numbness, but it was temporary, and it went away. 12 patients had some transient dryness of the nose, and some patients had recurrent septal deviation, which is not unusual. As you know, septum is cartilage, and sometimes the curve may come back. Intense itching was observed by 7 patients, and sinus infection occurred on 3 patients. Since then, we have changed the regimen for antibiotics, and we haven't seen this particular complications. So when we looked at the results, 82 out of 89 patients had complete elimination or significant improvement in migraine headaches. And this article has been published, so I'm not going to look into in depth. But we had 19 patients who served as 19 out of 25 patients who served as a control, followed up a year of care, and of those, only 3 patients noted some elimination of migraine headaches, not complete elimination, reduction in migraines, and nobody had elimination, only 3%. So, and we also included some tests that some tools that have been tested before, and they are reliable tests to gauge the quality of life for these patients. And every 10 parameter showed statistically significant improvement in the quality of life. And these tests included MSQ, MIDAS, and SF36. That are the tools that I, again, validated. The mean baseline treatment cost was reduced also significantly, as, again, you will see the details in the publication. And patients were able to reduce the time off from work or loss of time from work. It went from 4 days to 1 day. In conclusion, we concluded that the surgery is effective and safe. This was published in 2005. And this study had a 5-year follow-up of the same patients, and demonstrated that the results not only the surgery is not only effective, the results last. And there was no statistically significant difference between 1 year and 5-year follow-up. We did a 7th study that it is the ultimate study, because after getting approval from 2 IRB organization, which is the organization, as you know, to looks into the ethics of the surgery, patients who had single trigger site which was difficult to find enough patients to do the study, but we did, underwent either surgery, real surgery, or sham surgery. Sham surgery meaning making the incision, find the nerve, and not doing the operation. And this study involved two neurologists who were headache specialists and a biostatistician. And the results were the same. We actually demonstrated that the result of the surgery is effective and safe. Again, we looked at the safety measures, adverse effects as well. And this concluded, and this is a type of study that it is extremely difficult to get approval for. And this was published in 2009. And our strongest evidence for this operation is demonstration of the fact that the reality that patients who have migraine headaches are missing myelin. Myelin, as you know, is a membrane around the nerve. And what we did is on 15 patients who had migraine headaches and 15 patients who did not have any type of headaches, we biopsied the nerves and examined using proteomic analysis and electron microscopy, and demonstrated that, again, these patients who have migraine headaches had myelin deficiency. We have also demonstrated that migraine headaches work on adolescent patients, and again, this has been published. I personally, actually, this number is more, have published more than 40 articles, which again include retrospective study, prospective pilot, prospective randomized with sham surgery, and 5-year follow-up. And 5 other centers have confirmed our findings. So there's really no question that the surgery works. We now, for the last 10 years, focused on improving the outcomes and finding the most common reasons why the surgery may not work, and detection of trigger site, etc. So what I'd like to do now is focus on the clinical aspect. Last 15 minutes, I have shown to you that the surgeries work and is worthwhile. Now let's focus on the most important aspect of surgery. And we have demonstrated that the reason for the failure is failing to detect the trigger sites. As long as we have found the trigger sites, we can actually make these patients completely symptom-free. And the ones that they have partial improvement is because they fail to detect the trigger sites. So I'm going to focus on that a lot. But before I operate on the patient, I make sure that every patient who has the diagnosis of migraine headaches has been by a neurologist. To me, the family physician should not be the reliable source, not that they can detect it, but for the studies, for surgery, I want to make sure that these patients have migraine headaches. And when they call us to make an appointment, my secretary asks them to keep a log of their migraine headaches before they come to my office. And I'd be happy to share any of these forms with you if you just send me an email to bguyuron@guyuron.com. My first name, last name, and at mylastname.com. Then I will share these forms with you. So they come to our office having a form that tells me exact information, that gives me information that I need. And that includes a lot of information, including how often within that month had migraine headaches, how intense they were, how long they lasted, plus the other symptoms that go with migraine headaches to make sure that they have migraine headaches. And I use the symptoms that are associated with migraine headaches that the patients have provided me the information for, along with other factors, to decide where the headache starting from. So that includes, again, the constellation of the symptoms, where the patients pointing to where the headaches start from can point to the forehead, temple. I will talk about those from behind the eyes. If they use nasal decongestant, the headaches may go away. Botulinum toxin injection, I used to use it as a detection tool. I don't do that anymore for a variety of reasons. Not everybody responds to the Botox, and also some areas Botox doesn't work. If they have chronic occipital neuralgia, Botox is not going to work. If they have pain starting from behind the eyes, Botox is not going to work. The biggest tool that I use that I'm going to share with you is ultrasound to detect the trigger site, and CAT scan. So let's dissect each one of these first. When the patient is sitting across from me, my first question to the patient is, where do the headaches start from? And I ask them to show me the site where the headaches start most commonly from, and they are most serious, most severe. So, and as you have seen, we have published this article also. We have discovered 7 different trigger sites, and this is the study of 1,220 patients, who had undergone 2,700 procedures. So, in average, each patient has 2.5 trigger sites. 11% of the patients have only 1 trigger site. Now, let's say that the patient tells me that, okay, my headaches start from forehead and pointing to this area. And the next question is, how about a second trigger? So do I have headaches from any other side? Oh yeah, starts with my temple also. The next question is, can the pain start from the temple independent on the forehead, of the forehead headaches? If the answer is yes, we have 2 separate trigger sites. Sometimes the forehead headaches can travel to the temple after starting from the forehead, or temple headache can travel to the forehead. So it is crucial to differentiate those, separate them, make sure that they're independent trigger sites. So I ask this question enough until we get to a point that identify all of the trigger sites. It will be extremely rare to have, maybe 11% of the patients have the forehead, temple, behind the eye, or occipital headaches. And sometimes even the other trigger sites that I mentioned. That is extremely, extremely rare. Most patients have, as I mentioned, 2.5 trigger sites. So the next question is, okay, what is it you do to mitigate, reduce the pain? Many of these patients put cold compresses, or some of them, and if they don't volunteer, I ask them, if you press on the temple where the headaches start from, can you reduce the pain? Often the answer is, oh yes. But if as soon as I let my finger go, the headache is going to go away. So what does it mean to me? It means that there's a vessel, and what they are doing is blocking that vessel. And when we take away the flow, blood flow in the vessel, the headaches are going to go away. As you will see, that is part of the surgery. That's one of the things that we do. And and part of the reason that this starting point is so important, even in the temple area, the patient's headache can start from there. Can you point to the area of the pain? If they do, I'm going to listen to that area. Perfect. Just keep it there. This patient has actually pointing to a different area. Listen to what happens. So I'm going to mark the area, as you will see in a minute. Listen to my marking to make sure that I mark the right side, exactly where the headaches are coming from. So the alternative is to have the patient to point to the area, mark it, then listen to it. You can do it either way. The whole idea to make sure that we are marking the right area. And sometimes you have to move the Doppler around a few millimeters in different direction to find that pulsation, because the patient's fingertip cannot be 100% accurate or sensitive. So what about the nerve block? Does that help? If the patients have headache at the time of the office visit, nerve block is great. What I do is inject naropin, which is like Marcaine, long-lasting anesthetic. But before I do that, again, I'm going to mark the area, listen to the area, then inject it. And if the patient has a headache at this time, the headache may go away completely. And that's going to make that patient a believer that surgery is going to work, and you, as a surgeon, more confident that if you remove that vessel and the branch of the nerve, that the headaches are going to go away. So what if the nerve block doesn't work? Doesn't mean anything. Essentially doesn't mean anything. Let me explain to you how I explain to the patient the fact that a negative nerve block is not so important. What I tell them is, imagine that the migraine headaches are the consequence of branches of the trigeminal nerve that are like a tree. This is a discussion with the patient. I tell them trigeminal nerve is like a tree that has multiple branches. Imagine a tree catching on fire, and you pour water on the branch that the fire starting from. What would happen? You will stop the fire. But by the time somebody brings the water, the whole tree is on fire, and you pour water on the branch that it started from. What's going to be happening? You're going to be stopping the fire on that branch, but not the whole tree. And the negative nerve block is like that. By the time we inject the nerve, the entire trigeminal tree is inflamed. So elimination of injection of local anesthetic may produce some numbness in that nerve, but not the whole trigeminal nerve. So that is, the nerve block is going to work if we catch the condition in an early stage or in a localized stage. So let's start talking about the surgery, which is what we're waiting for. But before we do that, let's confirm that headaches start from that side. The first and the most important factor is the patient pointing to the area, telling me that the headaches start from here or this area, or above the eyebrows or the eyebrow level. It usually happens late in the afternoon. Stress is a factor. These patients have strong frowning muscles. They develop eyebrow or eyelid ptosis at the time that they have forehead migraine headaches. And the area is tender, and they usually respond to the injection of Botox. The reason that it occurs, the migraine headaches occur here, is because the trigeminal nerve branches, meaning supraorbital and supratrochlear nerves, are being muscles or the vessels, or they go through a foramen rather than going through a channel. We're going to talk about that. And the way I inject Botox, if that is what you're going to be doing, you notice how far. I ask the patient to frown first. Let's do that again. I'm going to ask the patient to frown, and you can see the end of the muscle. So I'm going to start from the end of the muscle as high as possible. Usually even I'm higher than that. This is what I do for cosmetic reasons as well. So I'm going to pass the needle, superficially inject. As I go medially, I'm going to go deeper and deeper. And that's what I do for cosmetic injection of Botox also. So there's no reason to have multiple injections. So that's the first thing that I'm going to do if I am injecting Botox. But as I said before, I don't use Botox as a diagnostic measure unless the patient doesn't want to have surgery. And the problem with the patients who have had Botox and all is that the muscle shrinks and it becomes pale, and you may not be able to see all of the muscles if you do operation soon after the injection of Botox. So you need to wait until the muscles recover before you do the surgery. And the CAT scan of the perinasal sinuses would help me. You can see that there's a foramen on the left side. There's a notch on the patient's right side. This is left, this is right. So I'm going to undo this foramen, as we will show you in a minute. Temporal migraine headaches are the consequence of irritation of the zygom, often the zygomatical branch of the zygomatical temporal branch of the trigeminal nerve, and that pain will be in this area, in very close to the eyebrow, not above the ear. That is a different nerve. We will talk about that in a short while. So, for these patients that pain is starting from the temple, you usually wake up in the morning with headaches. Stress is a factor, and they usually clench or grind their teeth at night, and they have trigger point tenderness, and TMJ is temporomandibular joint pain is often associated with this type of migraine headache. So they may have both. So, but fortunately, the surgery that we're going to do here may help the patients have TMJ pain also. Even injection of Botox is going to help. So the nerve exits from this area about 16, 17 millimeters lateral to the lateral canthus, and 6 millimeters cephalad. And when you run your finger in the temple area, you're going to find a hollow point. I'm injecting 25 units of Botox, dissolved in half a cc, and is being injected in a fan shape. This is for the temporal migraine headaches that is starting from this area, not up here, not in this area, and will respond very favorably. But again, I don't use that routinely anymore. These rhinogenic migraine headaches, meaning headaches that are starting from the septum and turbinates, start from behind the eyes. These patients usually wake up in the middle of night or in the morning with headaches. Weather change is a factor for them. Allergies make them worse, and hormone changes, meaning periods or intercourse, can actually initiate the headaches. And many of these patients have not rhinorrhea, meaning their noses run at the time of headaches, and these could be cyclic. And the reason these headaches start is because there's a contact point between the septum and turbinates because of the spur, or they have concha bullosa, initiating the triggering migraine headaches from this site that we're going to be talking about. When you look at the CAT scan on these patients, you can see a variety of pathology like what we see here. You can see a huge spur that touching the middle turbinate on this patient, who has also concha bullosa, air pocket in the turbinate, and paradoxical curl of the turbinates. The turbinates should be curling outwards. If they curl inwards, they send the air or direct the air to the septum, and that can trigger headaches. So there are multiple reasons intranasally can cause headache. So this is the animated view of the CAT scan that I showed to the patients, and you can see I discussed with the patient. You can see that actually the patients do not have to have medical degree to see this spur that I'm pointing to the contact point. Again, this is another patient, paradoxical curl, or sometimes again concha bullosa, and all of these the patients can see, and they don't have to be again in the medical field to understand it. Occipital migraine headaches are the consequence of irritation of the greater occipital nerve or the lesser occipital nerve. They are usually stress-related. Majority of these patients have a history of whiplash injury involving the back of the head, and heavy exercise can actually trigger headaches. You usually have muscle tightness and point tenderness, trigger point tenderness. Here, the main problem is as I discussed earlier, the greater occipital nerve passing through the semispinalis capitis muscle. And to inject this area, the patient lies down in the prone position, puts the hands under the head and the fist under the head, tucks the chin in, and helps me to find the tender point. And I'm asking the patient to point to the area. You will see that the patient is going to point to the area. And I'm going to inject that area, which is usually 3.5 cm from the occipital tuberosity and 1.5 to 2 centimeters lateral to the midline. And I'm going to inject 25 units of Botox in a fan shape, dissolved in half a cc for each side. So I'm going to inject 50 units of Botox for the back bilaterally. And again, is being injected in a fan shape. So with doing so, we can actually assess the patient, and this summarizes what we did to get to the surgical point. Neurologic exam, 1 month diary, pointing to the area where the headaches start from, and we make sure that if there are several sites, they're independent sites. I don't use the Botox anymore. Nerve blocks, if they have pain at the time of headaches, Doppler and CT. So surgery. If the patient has isolated forehead headaches, I'm going to use the transpalpebral approach that I described in 1993 and published in 1995 in the Plastic and Reconstructive Surgery Journal. And I have recently published a video of this in the Aesthetic Plastic Surgery Journal. By the way, I'm the editor of Aesthetic Plastic Surgery Journal, and I hope that you're using the time that you cannot use otherwise to gather your thoughts, study, and submit your articles to the Aesthetic Surgery Journal. I look forward to it. So, getting back to how we're going to do the surgery. It can be done under local anesthesia with sedation or general anesthesia. And also the book has all of these videos. So I want to, you can see the patients frowning, how strong they are. We're going to mark the patient in a lying down position, and the incision will be on the lowermost crease, lowermost upper eyelid crease. And you can see the patient looking up. I'm lying down, patient under anesthesia. I'm going to inject the incision with xylocaine containing 1 in 100,000 epinephrine, and make the incision while my assistant is holding the lid down, and I'm pulling cephalically using a 10 blade going through the skin only and cauterizing the vessels We're going to go through the muscle now. This is the orbicularis muscle. We're going to lift the muscle and dissect cephalically between the muscle and the orbital septum. Again, not below the orbital septum. You can see all the fat is within the orbital septum, and we're not touching that. As I dissect sufficiently towards the orbital rim, I'm going to use a pair of baby Metzenbaum scissors to spread and dissect more cephalically. And this is leading towards the supraorbital rim. And when I dissect enough, I'm going to see the first layer of muscle. This is the first layer of the muscle I'm holding up. That is the depressor supercilii muscle. Depressor supercilii muscle. It is not the corrugator muscle yet. This is the corrugator muscle. You can see how much darker it is compared to this muscle. And in fact, we're going to be seeing all three of these muscles on the same view in a short while. And here's the corrugator. And this is the orbicularis muscle. This is the depressor supercilii muscle. Depressor supercilii orbicularis corrugated. Or corrugated muscle is really firm muscle, soft muscle. And I removed the first muscle that I removed was the depressor supercilii. Now you can see that invariably when you lift up the depressor supercilii, you're going to see a good sized branch of the nerve that I'm going to repeat this video because I want to show this. This is the corrugated muscle. I followed this nerve down to the thickness of the muscle and then put a clamp across the muscle while looking at the nerve from the underneath. Then remove the muscle as thoroughly as I can, watching the nerves all the time in the deeper surface of the nerve, the deeper surface of the muscle. And I would do that and cauterize any vessels that are running with the nerve. Then remove some more muscle further cephalically. And the way you decide about this, asking the patient frown before starting the surgery, you know how much muscle you have to remove. I keep doing that in pieces. I'm not removing all of the muscle in one piece. And you can see that as you think that you have removed it all, you'll find some more muscle. As you see there, I'm removing the medial portion of the orbicularis muscle. And then we're going to go even deeper and find some more muscle medially, even the some of the fibers of the procerus muscle. These are still orbicularis muscle further cephalically, and I'm going to remove all of these pieces. Now we are looking at the nerve there. That is the supratrochlear nerve, not supraorbital. Supraorbital is down here. So I'm going to remove some more muscle there. Now we are decompressing the supraorbital nerve, and I'm putting in mosquito hemostat, pushing it down to identify the foramen, and then release the foramen if it is release the fascia if it is just a notch. If it is a foramen, we're going to treat it differently, and this will release the muscle. I'm putting a mosquito through to make sure that it is completely decompressed. Now I have the supraorbital nerve, supraorbital vessel, and we're going to remove the vessel, ligate it, transect it, and free up the nerve. And again, looking at the CAT scan, this patient has a foramen on the right side, and we're going to do an osteotomy, remove the foramen, either using a rongeur or a 2 millimeter osteotome on each side of the nerve, and remove the bone and free up the nerve. And you will see the nerve in a minute more closely. You can see how the nerve is narrowed. It doesn't always happen to see it like that, but on this patient, as you can see, the nerve was compressed a lot. And foraminotomy is complete. Then we will harvest some fat from the medial aspect of the upper eyelid, medial compartment, and place it in position and suture it in position using 6-0 monocryl, and repair the skin using 6-0 plain catgut. And often, before I close the incision, I inject some of the patient's own fat in the area where the muscle has been removed, besides adding some fat there. Or on patients who do not have extra fat in the medial compartment, I just inject some fat within the thickness before I close the incision in the periosteum and in the skin, not in the cavity, in the periosteum, in the skin, underneath the skin in the orbicularis, before I close the skin. If the patient has combination of frontal and temporal migraine headaches, then I'm going to use an endoscopic technique, as you see here, marking the incision. We're going to inject the area with xylocaine containing 1 in 100,000 for non-hair bearing area, and xylocaine containing 1 in 200,000 to hair bearing area. Use the endoscopic approach that we use for cosmetic reasons, and if you do that, you don't even need to listen to this anymore. The key to the success is to go down to the deep temporal fascia, as you saw here. I want to see that a grayish, shiny tissue that is the deep temporal fascia. Then we're going to place the endoscopic access devices that I have designed, and I have no financial interest on these, and they are placed in position. They are sold by a company called Applied Medical Technology in Cleveland, Ohio. Again, I don't get any benefits from designing these devices or instruments. So we will dissect area, we'll prepare our suction cautery, which is made by the Valley Lab, and this will help me to cauterize the vessels if they bleed. And I'm using the scope on the left side, periosteal elevator on the right side. We're going to dissect all of the tissues off the deep temporal fascia and periosteum, elevate the periosteum laterally and medially. And here's the dissection continuum. It is the sentinel vein that I preserve, and continued dissection in the supraorbital area. You're going to see the periosteum right there that I'm elevating and preserving the sentinel vein. And this is the nerve that we're going to avulse. Avulsion would allow the nerve to retract in the muscle, and the chance of neuroma will be reduced significantly. Then we will continue dissection along the orbital rim and supraorbital area, and medially to locate all of locate the muscle. But before I do that, I'm going to make a small opening in the area above the zygomatic arch to harvest some fat from the area deep to the deep temporal fascia above the zygomatic arch medially. The minute you make that opening, push on the buccal area, this fat pops out, and I'm going to harvest that to use it later for replacement of the muscles. Now I'm ready to remove the corrugated muscles after releasing the orbicular arcus marginalis. And you notice that the scope is in place, and is being held in place by my assistant, and I'm pushing the muscle against the scope with my index finger, and using this grasper, I'm going to remove the muscle as thoroughly as possible. Actually, you should say muscles, meaning the corrugator muscle, depressor supercilii, and a portion of the medial portion of the procerus muscle. And I continue this step-by-step avulsion until the nerves are completely denuded and I'm seeing the subcutaneous plane. I remove the muscle even above the nerve, as you see there. And the idea is to get to this plane, as you will see on the next slide. And here's that, as you see that you think that you have removed it completely, you're going to find some more muscle that you can remove. And this is the end point, seeing the fat in the subcutaneous plane in this area. And after I complete that, we're going to place the fat that we harvested from the above the zygomatic arch and place it in position. Or if I don't remove any fat, I'm going to inject the area with fat that is harvested from the abdomen and prepared after being spun, and place it in position. Here's a fat graft being delivered to the site, and another fat that I molded in position. And when you do that, you can see that these patients have no movement of the muscle when they frown, and they look prettier, younger as well. For isolated headaches in the temple area, I'm going to use the same technique, but only use the lateral incision. It is the endoscopic approach. We're going to dissect, place the access devices in position, and use the elevator, which is called ovigator elevator, elevate the tissues above the deep temporal fascia, get to the nerve, and either avulse the nerve, or, and you can see the nerve in view, I'm separating the nerve from a vessel, and then I'm going to actually, on this one, I'm going to decompress the nerve rather than avulsing it. We have demonstrated that both techniques produce equally good results. And to decompress, I'm going to use a special knife, as you will see in a minute. It's a sharp knife that, after the vessel is ligated like that, we're going to use that knife to incise the fascia lateral to the deep temporal fascia, lateral to the nerve. But again, it is easier just to avulse the nerve. I have not seen issues related to that. So avulsing the nerve is the best way, as you see right there. And repair the incisions. If the patient has migraine behind the eyes, we're going to do a septoplasty and eliminate this spur and pack the nose initially with afrin containing gauze, inject the nose with xylocaine containing 1 in 100,000 epinephrine, do a septoplasty as you are all familiar how to do, and remove the spurs that are protruding into the septum, into the turbinates, and place back the straight portion of the cartilage, as you see right there. This would minimize the potential perforation. Put the stents in position and suture the stent in position. For the occipital migraine headaches, first, in a sitting position, I want to identify the midline. And this is the only surgery that is sort of radically different from what we normally do in the plastic surgery field. So I've marked the patient's occipital area. Patient is anesthetized, turned over. Shoulders are pulled down using tapes to expose the area. The area is draped, and inject inject the area with xylocaine containing 1 in 100,000 epinephrine, and then make the incision in the midline and put the retractors in position. Use the bovie to go down to the midline raphe. We need to make sure that we stay in the midline. After we get to the midline raphe, then we're going to dissect further laterally over the midline raphe, over the trapezius fascia, and then we go off the midline now and make an incision off the midline, leaving about a centimeter of midline raphe intact for the stability of the head. So the midline raphe is preserved on this side. Actually, you can see on this side and on this side. Now we have made the incision. You may encounter the trapezius muscle fibers that are attaching to the midline, which is rare. If you do, you go through those. They are oblique muscle fibers. Trapezius muscle has oblique fibers. So you go through that and you find it, as you go through that, you're going to find deep to it the vertical fibers of the spinalis capitis muscle. And in that plane, we're going to continue the dissection. Here's the semispinalis capitis muscle. You see a few fibers of the trapezius is still there. We're going to be removing those later. So I'm isolating the nerve, and you cannot miss it. Essentially, every resident of mine is able to find this nerve, even if without me being in the room. And this nerve is good sized nerve. You will find it if you are in the right plane. If you are superficial and above the trapezius muscle, you're going to be lost, unfortunately. You're not going to be able to find the nerve. And if you can't find the nerve, please go deeper. It means that you're too superficial. And we will put the vessel loop around it, then dissect around the nerve, go down and remove a portion of the we are releasing more of the muscle and going deeper and deeper. Then we're going to isolate the muscle from the midline and remove a segment of the muscle. Actually, let me go back to that video for a second. So we are isolating the muscle, and we're going to remove a rectangular piece of the muscle as a segment from the midline to the nerve. So whatever is between the nerve and the midline, we're going to remove it completely in a shape of a block, which is about 2 centimeters, usually is about 2 centimeters wide and 2 or 3 centimeters long. And you can see the muscle is being prepared. We're going to excise that muscle. Now I'm isolating the muscle from the midline raphe again, or deeper to it. And now we are ready to remove that segment of the muscle as a block. And this is very important. So I'm showing the entire video. So we're going to transect the muscle, as you can see, and then pull it down and remove the cephalic portion. You will see it in a minute as a block of the muscle. Now we are transecting, we're going to be transecting the muscle in a second. And this will isolate the nerve in the midline. Here's the transection of the muscle. After we do that, we're going to remove a portion of the trapezius muscle that extends to the midline, or trapezius fascia, like you see right above the nerve. This is the nerve. We're going to remove a segment of the fascia to decompress the nerve. And after that, I'm going to remove any piece of fascia like carpal tunnel surgery overlying the nerve. And if you can see, we're going to keep doing that until the nerve is completely exposed, until we get to the subcutaneous plane. We'll continue doing that. And sometimes you can see a vessel like that bisecting the nerve. Actually, you can see in between two branches, there's a vessel. I'm going to ligate that and remove it, like so. It is, and for that, I use a bipolar cautery. And then we're going to raise a flap, a quadrangle flap, a 2 cm by 2 cm or 2 by 3 cm flap, like what you see. And we're going to cut the cephalic portion and mobilize this as a caudally based flap, and is going to be passed under the nerve, as you see right there. That's the flap going under the nerve. And then we will suture these two flaps, one from the right, one from the left, underneath the midline raphe to each other, like so. This is a monocrystal suture. The needle is being passed. We're going to catch the flap on the other side, bring the needle back, and tie it. This way, there's no way that these flaps will slide from underneath the nerve and will remain in the. Then I'm making a hole under the midline raphe to pass this drain that is going to be passed through the skin under the midline raphe to drain both sides, and will irrigate the wound, repair the incision using 6-0, 5-0 monocryl, reattaching the subcutaneous tissue to the midline raphe, eliminating dead space, and 5-0 plain catgut for the skin repair. These patients not only have migraine free, they also have they look better, and the airway would be improved. There are less common side, lesser occipital, auriculotemporal side, and third occipital and terminal branches. For these, I just make a tiny incision on top of the nerve, as you see the Doppler showing the vessel. So you heard the sound. Inject the area with xylocaine containing 1 to 100,000 epinephrine. Incision. We're going to go down, remove the vessel, remove the nerve, because we're running out of time. I'm not going to show the entire. That's the vessel right on top of the nerve that is going to be ligated and removed, and that's the superficial temporal artery branch. Or I would remove the entire superficial temporal artery or auriculotemporal nerve. For the lesser occipital, the same. We're going to listen to the area, find the vessel, and make an incision right on top of it. Go down after injection, find the nerve, and remove the nerve, cut the nerve, bury it inside a muscle, and that would take care of this surgery as well, this site as well. And usually the nerve is that big, as you see right next to the muscle, and we're going to bury it inside the muscle and repair the subcutaneous tissues. This is very easy. These are the patients that can go home the same day and go back to work the next day, or go back to work even the same day. And we get somewhere between 80 to 90% response rate. Majority of these are elimination. In summary, I have shared the evidence behind the science of this surgery and detection of the trigger site, and surgical techniques that would address the problem, and evolution of the anesthesia. And again, many of these patients who can point to the area of the headache precisely, and you find a blood vessel, you can go down and remove the vessel, remove the nerve, and you'll be fine. And the patient is going to become symptom-free. I hope that this helps. And this is the most rewarding surgery that I do. And those of you know me, I've contributed a lot to the plastic surgery over the last 40 years, but this is my most thrilling contribution, and it gives me a pleasure to share it with everybody. Thank you.
Thank you so much, Dr. Guyuron. Your presentation was really didactic and clear, as always. I'm sure that everyone has learned a lot from you. May we open for some questions from the audience?
Yeah, please.
Can you see it?
Okay. Excuse me.
Okay.
No, not actually. We haven't done this study on 2,000 patients, but we are doing that now. We are actually going back. Unfortunately, I residents around me, medical students, we're going back and reviewing everything on patients. I know for a fact that I have patients that I operated on them in year 2000. They're still symptom free. I know that because I see some of those patients. But we're going back and reviewing everything that we have done over the last 20 years, and hopefully sometime in the near future, I'm going to share all of what we learn with everybody. But we have done a huge number of studies on different sites on larger group of patients, some on 250, 300 patients. So we're going to be, there's no question in my mind that again, it works.
Okay. There is another one here.
Dr. Guyuron. This is a great question. The question is, how often do you reoperate? In the beginning, I was reoperating more so than I do now because I was not aware of all of the trigger sites. Now I insist on finding all of the trigger sites and operate on those. We even published a study going back to maybe 2010 or 2008, going back to see how often actually our patients have a second or third trigger site. At the time was 17%, but today is fewer. I can't say that I can help every patient. I can't say that I can help every patient to become migraine-free with one operation. But if when the patients stay with me and let me to do what I need to do, in majority of the patients, I can take the migraine headaches away. And usually, after the first operation, even though they may have some migraine headaches, in general, they are fewer headaches. They are less, meaning less frequent, less severe, last longer, last shorter, and they respond to the medications a lot easier, a lot more effective. The medications become more effective for them. So any way you look at it, even first operation is, on most situation, is beneficiary.
Okay. If you need to operate again the same patient, Dr. Guyuron, how long do you wait for it?
Yeah, it depends on the trigger site. Almost never before 3 months. But if the patient is from out of country and is in town, and I operate, let's say, on lesser occipital area, next week, next 3 days, 4 days, the patient tells me that I have no headaches in the occipital area. But since you operated, I have noticed that I have actually temple headache exactly here. I may do that patient's surgery under local anesthesia, but usually I'm going to be waiting 3 months before I operate on a additional site. And going back to the question that I was asked earlier, when I reoperate, almost never is exactly the same. I mean, I should say almost never. When you do thousands of something, you may find few millimeters difference between where you operated, where the second site is, but that would be exceedingly very, very rare. Usually is another site that I'm operating, not the same site.
Okay. A common question, Dr. Guyuron, that we were talking about before your lecture is, and I think it's good for everybody listen, is how has been the relationship between the plastic surgeons that do migraine surgery and the neurologists and the neurology societies in the US?
Yeah, one of the reasons that I referred to the placebo effect commonly, you may hear the same argument from your neurologist in Brazil that this is all placebo. But you saw the patients started this, we didn't. And in the beginning in the United States, that was the main argument, even up to 10, 15 years later, even though I showed that some of these patients had five-year follow-up and no placebo effect goes away in 5 years. So many of the neurologists who were in a top level and were against the migraine surgery are starting actually to do some studies, are involved in some of the studies that show involve surgery. So, and they are, more importantly, they are now doing the studies to prove that migraine headaches are peripheral phenomenon. One of the main objections, one of the reasons that I had so much resistance from the neurologists because they were telling me that you're turning our theory upside down. We think that migraine headaches are central phenomenon. While my doctor patients who were doctors who had migraine headaches, when I told them that I think that this is the peripheral branches that are irritating, would smile and tell me, I feel the same. So the patients agreed that these are, in the beginning, these are peripheral phenomena. I was convinced that the migraine headaches are peripheral phenomena, but the neurologists were resistant. Now they're coming around. They actually have done studies to prove that many migraine headaches are peripheral phenomena, starting from the branches of the trigeminal nerve or occipital nerve. So I think it is going to change. It is changing. And it took 20 years for gastroenterologists to accept that gastric ulcers are caused by bacteria. And the guy who talked about it first had to leave Australia because they didn't believe him and they actually didn't like him there. So I'm hoping that one day the neurologists are going to accept this.
Yeah, okay. There is another question here. How was the FDA approval process for the surgery? And the other part you have already answered.
No, actually, in the United States, we don't have to have a FDA approval for surgery. We need to have approval, FDA approval for medications, but even for medications can be used off-label. So I never applied for an FDA approval for this surgery, and I don't even know how many surgeries that we do actually are FDA approved. Implants are FDA approved. Plastic surgery anytime we insert a device, foreign material under the tissues, it has to be approved by FDA. Sutures are different, and especially absorbable sutures. And there's no device that I'm using to have FDA approval.
Okay, this colleague asked this before because it is very common here in Brazil that neurologists and other colleagues telling that the procedure is experimental and we could not do it. But as you said, if it is max as off-label procedure, we just do peripheral nerve surgeries, so we don't need any other thing to be approved.
Yeah.
And do the insurance companies in the US do they approve the surgery, Dr. Guyuron? I mean, do they?
Yeah, it depends on the type of surgery and type of insurance. Medicare actually Medicare pays for all of the migraine surgeries. Private insurances still call it experimental 20 years later. Not all of them, though. Some cover, some don't. And if we do, for example, something like septum surgery, it is covered by most insurances in the United States.
Okay. Another question from the audience, Dr. Guyuron.
Okay, the question is, I would like to know which has improved your results more, using Doppler as a diagnostic tool on every patient, or fat grafting patients with fat grafting for recurring pain. They really are not comparable. They're different things. And what this question is referring to, for patients who undergo surgery and they may develop some neuritis type, neuralgia type pain, I inject fat, and that works. But Doppler is a different tool, and is a tool for diagnosis. So I use Doppler on everybody who can point to the area. Obviously, we cannot use it for the pain behind the eyes, but for any other trigger site, I'm going to use the Doppler for the diagnostic reason. So they're different modalities, and I use them in different occasions.
Yeah, Dr. Guyuron has published a paper about it. That's maybe because of these that the colleague asked him, that the minority of patients that don't have complete relief after the surgery, he does fat injections to the sites of pain, and many of them, they get better, right, Dr. Guyuron?
Right. Yeah, actually, that's been published in the PRS. I think we published it about 4 or 5 years ago. It could be longer, and the time goes by so fast, and demonstrated that fat injection would help the headaches that do not go away with surgery.
Okay. Another question, Dr. Guyuron.
Fat injection, fat grafting or fat injection? I assume that fat grafting is you have to do surgery to do fat grafting, but fat injection, the answer is yes. I think that it is quite likely that is going to help. I don't believe that it's going to be. In fact, studies from Italy on a very few patients show that they get improvement, but I don't think there's going to be, even in my experience, we got good results, but the results were not comparable to the surgery. But on the other hand, combination of fat and Botox injection could be an answer for some of these patients because they work differently. They do different things.
Okay. And Dr. Guyuron, what is your suggestion or orientation for the colleagues that want to start doing migraine surgery? how should they start doing it?
Okay. Essentially, 1 out of every 5 female patients that you see has migraine headaches. The first thing that I'm going to suggest is incorporate in your office questionnaire question about migraine headaches. You need to ask the patients, if they have migraine headaches. So if they do, and also remove the muscles, then if they have forehead headaches, would help your headaches. It may help your headaches. And it helps. You send a note to the neurologist saying, I saw so-and-so patient of ours, and I'm delighted to let you know that after the migraine surgery, her headaches have reduced or gone away. That is how you start. If you have 100 patients, you see 100 patients, female patients in a year, you have 20 patients who may have migraine headaches. That if you are going to be operating on them, doing breast reduction, augmentation, body contouring, that have headaches, they could be your migraine patients. That is how you can get started. And then connect with some neurologists. Not everybody is reluctant, and you're going to find some neurologists that have an open mind about migraine surgery.
Okay. We're almost 1 hour and a half here, Dr. Guyuron. I don't want to take more of your precious time. I really want to thank you so much for your presentation and for your time with us. And I hope to see you soon, and that this pandemic goes away soon also.
Thank you very much, Paolo. And I wish all of you safety in such a difficult time. Enjoy the rest of your afternoon, evening. Thank you.
Thank you very much. Stay safe.
Goodbye.
Bye-bye.